Our next speaker is Dr. Alan Budney. Alan's a senior psychologist researcher who came to us just 2 years ago, or a year and a half ago now. He's been a colleague of Lisa's and many others for years, since they all were at the University of Vermont. And Alan, many of you know, is an expert in marijuana addiction, and he's also an expert in treating adolescents, if that's possible. So I'm happy to introduce Alan Budney.
All right, thank you. It's a pleasure to be here. My talk's on online delivery. It's a little bit of a misnomer in that the treatment that I'm going to talk about, just so I remember to tell you, actually mostly happens in the office. It's online, but in the office. Anyway, what I'm going to do today is go lower tech than our last couple of talks. Those sensor things, et cetera, and the games are great, but I am working in a technology area that's more like what Lisa Marsh was talking about, the TES program, if you remember that from the first talk today. And we're trying to use it to solve a particular problem. So my plan today is to describe a little bit of my historic work in treatments for marijuana dependence, and in particular describe our work on computer-assisted treatments to illustrate how technology-based interventions can promote access. And the access is kind of the key part for efficacious interventions. So unfortunately, like when I get to my screenshots, they don't look anything like Lynn's that are beautiful cartoons, et cetera. Mine are pretty boring. Sometimes boring's not too bad. Anyway, to get you going, I kind of have to bring you up to speed on the status of psychosocial treatments for cannabis use disorders. Oh yeah, and the other nice thing about being here today is that hopefully this doesn't diverge somehow into medical marijuana talk. Everywhere I go now, somehow the conversation shifts to medical marijuana. This has nothing to do with that. This is about treating people who actually are trying to quit or want to quit marijuana, and there are actually a lot of those. Anyway, there are a bunch of effective behavioral treatments that we and others have developed over time and tested in efficacy and effectiveness trials. And the three types of interventions most often cited are motivational enhancement therapy, cognitive behavior therapy, and contingency management, in particular abstinence-based contingency management, which means you provide incentives for somebody who's achieving abstinence. Now, the problem with these efficacious interventions, like the problem with most efficacious interventions in mental health, is getting them to the people, so limited access. In particular, contingency management is always kind of criticized as, oh, it's too costly, we can't do that, even though it works very well. But even MET and CBT are very hard to train up, to get therapists up to speed. There's not that many that do it that well, and to keep good quality going is hard to achieve. So that's been my predicament over my career, is to try to develop these treatments and now see how are we going to get people to do them, and how can we do, even in our trials, how do you get the people to do them well? So to give you a feel for what the data looks like when you treat adult marijuana users, and we're not going to talk about adolescents, that's a whole other line of research, but this is all about adults for the moment. Some of it can be applied elsewhere. But anyway, this is the data from the largest trial, multi-site trial for adult marijuana users. Whoops, I didn't mean to do that. One of these things is okay, there we go. Okay, so this is a multi-site trial. There's 300 to 400 people in this. And basically, this slide is looking for % days of use in 3 different conditions. One is just delayed treatment control, so they get no treatment. This is a combination of MET and CBT, the yellow line, and this is MET only. So there's a combination MET, CBT, and MET only. One's 2 sessions, one's 9 sessions. And this is the magnitude of the reduction in marijuana use you get over time. So baseline, everybody's using almost every day, 100%, 90% of the days. You get down to about 40% with a combined treatment. The lesser treatment is also effective, but not as effective. And over time, this is what you get. So the next step is, what about abstinence? How many people actually quit? Well, the quit rates are only down around 20%, even for the best treatment, this MET plus CBT, over time. So this is kind of where my research came into the picture. We were trying to figure out how can we do better than that. Those are the effective treatments, cognitive behavioral things. They work well. Everybody sees those as the treatment of choice. But I was working in the area of contingency management with cocaine, and if you can add incentives or motivational incentives to any type of behavioral treatment, usually you can get better outcomes. So we applied that concept to marijuana quite a while ago. This is a study published in 2006. And what this study is showing you, and it's important for the rest of the talk, is we compared 3 treatments, one of these contingency management alone, the combination of MET CBT and contingency management, and then just MET CBT. And this is at the end of treatment, and the percent of people that are abstinent, the 2 treatments that get CM are doing better than just the MET CBT. And over time, the key is the combination treatment does best. So if you add this MET, CBT, and CM together, you get the abstinence in the beginning, and the MET, CBT theoretically keeps the abstinence going over time. So that's, in a sense, the gold standard treatment out there, at least in the research world, clinical research world. And then a group from both Yale University, School of Medicine, and a group from UConn have replicated this same type of studies and show that this is basically the best thing we have at the moment. So the problem is, nobody delivers this. And everybody complains about, oh, we're not going to give incentives, nobody will do that at a community clinic, and when you see what people do and they call it MET CBT, it gets you upset because that's not really very good therapy, can we do it better? Anyway, there are all kinds of problems with access. So that's the problem that needed to be solved next. And colleagues of mine, Lisa and her ex-mentor Warren Bickel, started working on this TES program. And it dawned on me in a little while that one of my problems is having to train therapists and keep them around, etc. And MET CBT, what Lisa called CRA, it's pretty similar, the CBT piece, seemed to work pretty well compared to therapists. And my problem was I needed to somehow be able to pay for my incentive program and not have to deal with all the hassles of training and maintaining high fidelity treatment. And computer-delivered therapies seem to be a possibility. So Lisa put all these up earlier, all the potential benefits of computer-delivered therapies. I highlighted in yellow the ones that are kind of specific to this project, but you get the picture of the things that can possibly accomplish. You can reduce the cost of delivery, you can ease the burden associated with therapist training, ensure integrity and fidelity of the treatment. I mean, if you actually create a good treatment, it's delivered the same way every time, so you're in good shape. Perhaps you could even use some of those learning technologies to do a better job than a person could do because you can get repeated access to it, et cetera. All these good possibilities. So people have been working in this area long before I started working in this area at the same time, and basically they have computer-assisted or computerized versions of CBT, of motivational enhancement, and some computer-assisted contingency management. And I won't go into that literature, but it's a pretty well-developed literature now, and usually whenever they compare these things, they work pretty well. Not huge studies, but Lisa gave you a feel that they tend to work. And so our problem, as I described, is we have this gold standard, it's not available, incentives are too costly, training therapists is hard, especially to get high fidelity, and keeping them around. And it's costly. So here's the problems. If the computer can deliver the MET CBT, perhaps the cost savings related to the therapist, what it costs to pay the therapist and to train the therapist and to keep supervision and monitoring going on to get high-level treatment, maybe somehow cost savings with MET CBT via computer can be switched over to pay for the incentives. So that's what we set out to do. That's the problem we tried to solve. And so first we had to develop a computerized version. So pretty much we took this TES system that Lisa told you about, and her husband Mike Grabinski helped develop the software. He's the main man behind the scenes. We got Mike to go ahead and make some innovations and some modifications to the TES system. He tells me now that it's not really a TES system, but it's based off the same framework. But we just wanted to take the manuals that we've used to effectively treat cannabis and kind of translate and make sure they translate well in the TES system. So we created all these modules that were specific to cannabis. We created motivational enhancement modules, which didn't exist at TES in the time. I don't know if they're part of it now, but there wasn't a motivational enhancement piece to it. And we wanted to add that. We wanted to add a few other things that we had in our original treatments, which was a lifestyle goal setting module and some relapse prevention modules. We also wanted to make sure it was web accessible, which back then it wasn't, now it is. So that way, if we did the treatment one in the clinic, they could also work on it from home if they could get into their program. And now I basically just want to tell you what this is about and give you a little bit of a feel for what this system looks like. There are two MET modules. So motivational interviewing. Who knows what motivational interviewing is or motivational enhancement therapy? Most people. Okay, so pretty much it's just a dialogue. Usually you have a personalized feedback report based on your assessment. You do a comprehensive assessment with folks. And then you have a dialogue about their personal goals and how marijuana might be affecting those goals. And there's some social norming built in. There's a bunch of different things. It's a little hard to imagine how the computer would do that, but we tried our best with Mike's help to figure out how the computer would do that. And this is the screenshot from one of the modules that delivers MET. And one of the things you do is first you ask them about their goals in their life. What kind of goals do you have for your life? Once they kind of write those down, the next step is they'll see their goals listed on the left, and they'll say, how does marijuana affect your goals? Positively, negatively? So just get them thinking about how marijuana affects their lives in the best way we could think. Then it has things like, well, how much money do you spend? And their assessment said, oh, you spend $300 a month, $3,600 a year. And then it says, well, write in what else you might want to spend that money on if you didn't spend so much money on marijuana. So these are all the traditional kind of things that happen in an MET interview. Then you do something like, well, if you did change your use, what would the potential pros be? What would the cons be? And pretty much the computer spits back out what you listed as the costs of changing your marijuana use and the benefits. And you get this little scale. This is the traditional cost-benefit scale for MET. So we tried to make this happen. Then we worked on developing CBT modules. That wasn't so hard because pretty much the TES is a bunch of CBT modules. And so we took what was there, just modified it a little bit, make sure it was specific to marijuana, a couple different exercises, etc. And Lisa gave you a feel for what those look like, but a little bit more. You can't see this very well in the back, sorry, but this is just the menu they see when they call up their own TES program, where they go in and put in their program, their own password. And it just lists all the sessions, and they would just click on session 7, and they would get introduction to problem solving, and it'd take them to another screen. And when they first sign on, when they first get to that screen, first it'll just say welcome back. And they'll have on a pair of headphones, and it's audio eyes, so they can either read it or listen. And this guy with this nice radio voice says, welcome back, you know, and he's okay. Anyway, you get the feel. This is, hopefully there's not audio. This one has audio, but I'm not going to play it. But this is just a screenshot of what happens when you introduce them to the notion of refusal skills. And it takes you through the steps of effective refusal skills. And then part of that module shows you a video of someone doing a bad job of refusing drugs as they walk down the street. These guys started asking this guy if he wants to get high, and he says, I don't really think so. And they eventually convince him to get high, and then you can play the next vignette, and he effectively refuses marijuana, etc. Then there's all these tests built in. Part of the learning technology behind this is that you're trying to make sure they have actually learned what you're teaching them, these coping skills you're supposed to learn. And so at the end of the assertiveness training, it'll say assertiveness refers to all the following except. You have to answer it. If you get it wrong, you know, it tells you what the correct answer is. It tells you why. It makes you go back and take it again. So it's kind of trying to guarantee that people are more likely to learn what they're supposed to be learning. And the little piece that's computer assisted about contingency management is when they first log in, they also see a progress graph of how they're doing in terms of earning incentives. This is how much money, this is the end of treatment for this guy. He'd been in treatment for 12 weeks, twice a week urine testing, so there's been 24 times he's been tested for marijuana. Over that time, he's earned $234 incentives because he was staying clean, then he had a lapse. Got a clean test, lapse, clean test, clean test, clean test, lapse, clean test. So that's kind of the way these graphs gives you a visual picture of how you're doing. So that's the MET CBT, just a nutshell of how this works. And they basically come into our clinic like they come in for a treatment session, but the therapist doesn't have to be scheduled, et cetera. A staff support member can just sit them down and get them started. They do this whole thing on the computer. Anyway, so we set it all up. Took quite a while to figure that out, longer than we had hoped. But anyway, first we conducted a quasi-experimental pilot study. This was published in 2011, so it's been around for a while. But the way this worked was we ended up with 38 people, so it's a small study. But the first 16 just got the therapist treatment. So we're training up our therapists, and while we're waiting for the software package to get developed, they get this. Then the next 10, the software package is developed, they get the software, they get assigned to do the computer-assisted treatment, and the next 12 we randomize, and we threw them all together for a pilot comparative study. So the way it worked is 2 conditions. You have the therapist-delivered MET CBT CM and the computer-delivered. The difference is the C and the T there. Anyway, it's a 12-week study, 12-week trial. They get twice weekly urine testing. Everybody gets the incentive system for staying clean from marijuana. We ended up with 22 in the therapist condition and 16 in the computer condition. In the therapist condition, you get 9 MET CBT sessions with a therapist, 45 minutes to an hour each, a traditional kind of model. In the computer-assisted version, you get those same 9 sessions delivered by the computer. And you also get assigned a therapist to see 3 different times. You only see the therapist for like 15 to 30 minutes. They're there to just be supportive, make sure you understand the computer program. If there's any crises, they'll help you out. They're available if you do want to call and set up an appointment. But pretty much, they're not doing MET, CBT, or anything that's supposed to look like MET, CBT. They're just there for some support. And the computer program, like I said, you can also access from home if you have internet service. So the first study, these are what the patients looked like. They were all seeking treatment for cannabis use disorder. This was down in Little Rock, Arkansas. About half were male, half to 3/4 were white, the rest were African American. Average age about 30. That's the average age for adult trials with cannabis. They used marijuana about 80 to 90% of the days. 3/4 of these met criteria for marijuana dependence. The other quarter met criteria for marijuana abuse. We ran them through the study, and this is what the data looks like. It's pretty straightforward. This is urine test attendance, so twice a week they're supposed to come in and give their test. This is coming to your MET CBT sessions, either with a therapist or the computer, attending the clinic, and pretty much you see no difference between conditions. It looks like the computer might be doing a little better, but there's no statistical difference. So attendance, acceptability seems to be fine for the computer. Abstinence rates, what you have here is the percent of participants that are abstinent from marijuana for more than 4 weeks or more than 8 weeks, and you see the computer conditions in red, therapist in yellow, no difference between the conditions. So again, it looks like maybe the computer does a little better, but there's no difference statistically. So pretty much this demonstrated that, then we also asked them how they liked the computer software program. I always think these ratings are biased with social desirability, so they're pretty high. The lowest is 7 out of 10 on how useful was it, how relevant to your life. They give it good scores. I'm not convinced they liked it that much, but they certainly didn't complain a lot about it. Some people say, oh, I already know everything, and some say it's God's gift. So it varies quite a bit, but none of them really complain. They usually run through it without any hassle. We were also interested in trying to figure out, are there cost savings? That's the main purpose of this. Are we saving some money? And this first study, we didn't do a cost analysis. We just tried to figure out how much time's being spent where, because time is money. And so over here you see total time with the therapist, and in the therapist condition it averages about 480 minutes per patient. And for the computer condition they spend under 50 minutes with a therapist throughout the study. Meantime, they spend in the sessions themselves. So when you see a therapist for MET CBT, you spend about 45 to 50 minutes. And when you do a CBT module on your own on the computer, you only spend a little bit under 30 minutes. So the patient's saving some time, and you're saving therapist time. So both ways, it's kind of a win-win if it works as well. So this first little study pretty much just showed what you saw, pretty clear. These seem to be equivalent. The computer-assisted treatment was highly evaluated, and potential savings. So the limitations is this isn't a randomized study. It's a small sample. There's no control or comparison group, so really both treatments could be bad. If you never know, they're both not working. They're just equally bad. So you need a control group. And there's no post-treatment follow-up. That's the key piece. Because if you look back to that 2006 study I showed you, we didn't need a therapist of any kind to do as well as the MET CBT combined with CM. CM alone did just as well during treatment. So during treatment, you can get abstinence rates. You don't need a therapist. It's post-treatment where the MET CBT had its effect in our earlier studies. So the next study needed to look long-term, how well can the computer maintain these effects? And so this study's done too. This one's under review. Hopefully it get published soon. This time we have 3 treatment groups. The control group is an MET 2-session only group, and then we have the same treatments I just talked about. And this time we're going out 9 months post-treatment to see how well the effects maintain if we get them again. And we also have a more formal cost analysis this time around. And a fellow named Mick Tilford down in Arkansas, health economist, helped us with this. The sample population looks pretty similar. It's a little bit over half that are male, a little higher, more than half are African American in the second trial. The average age around 34, 35. Again, they use marijuana on 80 to 90% of the days. They started using when they were 14 or 15 on average. Quickly to the data. This is attendance data again. So the 2 MET CBT groups, pretty much no difference in session attendance. This time the therapist one slightly higher than the computer one, but no difference at all. When you look at abstinence, this is the amount of abstinence they achieve during treatment. And again, the 2 CM conditions, computer and therapist, do better than the MET, so we do know they're effective or efficacious, and there's no difference between these groups either. It's a little bit different this time. Therapist is slightly better, but it's not statistically significant by a long shot. Here's the slide that really matters, what happens over time. So right here at the end of treatment, we got about 50%, 45-50% of the 2 active groups staying clean, doing much better than the control group. Over time, the red bar is the computerized therapy, and the yellow bar is the therapist-delivered therapy, and the computer-delivered therapy is doing at least as well as the therapist-delivered therapy over time. That's what we wanted to see. These aren't really statistically significant when you collapse over time, but we know they're at least doing as well, if not better. It looks like the computer's doing better, but again, we can't show that clearly. So that's what we're looking for. It looks like the computer can also help maintain the effects we could get with a CM. And how much do you save? We costed this out, and I won't go into the details, but it was a fairly sophisticated cost analysis. You save about $350 per case. So the therapist-delivered one averaged about $600 in cost, and the computer one was about $230, same as what MET cost. And so you get fairly equivalent outcomes, and you save yourself about $350. So the conclusion is pretty straightforward. We were trying to figure out how do we solve this problem? How might we make it more affordable and increase the reach of MET CBT CM for cannabis and perhaps other types of drug use disorders? And pretty much we showed what I just presented. And I don't really need to go over this again. I don't think you get the picture. The implications are, perhaps, and we haven't tried to do this yet, it's easier to put MET CBT on a computer and get somebody to do it, save some money. Therapists can be doing something else in your treatment center, or you don't have your therapist, one way or the other. I usually don't hold back from saying maybe this could replace therapists to some degree, and they can be doing something else. It is what it is. And you can save your money, and you need those incentives. Those incentives, contingency management, is the most powerful treatment we have in our substance use disorder armamentarium. That's what we got. And we know when we try it with cocaine, opiates, et cetera, it can increase our efficacy rates anywhere from 20 to 40%. Got to find some way to put it into the picture. This is one possibility. The limitations of my research, these little studies, they're both fairly small. There's some missing data. So it'd be nice to somebody to replicate it in a bigger trial. In the comparison studies, we only have 2 therapists. So we are comparing 2 therapists to the computer. You know, the 2 therapists, we did some fidelity measures. I characterize them as very average, maybe slightly below average. They didn't get super high fidelity scores. So it's possible somebody with higher fidelity, MET, CBT, maybe they could compete with the computer a little better. But by and large, we supervised and monitored them very carefully, and you get what you get. These were some very good therapists for the area, but the quality of the MET CBT is still pretty average. These trials are only testing MET CBT in the context of CM. So it's really not a test of MET CBT with a computer versus a therapist by itself. That said, others have done that. There's a woman Frances K. Lampkin in Australia. She's done a couple studies, kind of just like mine, but there's no CM. She has a little bit different MET CBT program, probably better than mine, and she gets equivalent outcomes, sometimes slightly better using the computer rather than the therapist with cannabis users who also have depression. So it's pretty impressive. How are we doing for time? Okay, all right. What I thought I'd share with you just quickly is where we're going from here. So I haven't followed up on that. I'm not trying to implement it in any way. I'd love to get together with someone who wants to do a large-scale trial or figure out how to get it into a treatment center. But scientifically, what we've moved on to is the issue of cannabis and tobacco co-use. And we're using that same program to go after that. So we're trying to combine our gold standard cannabis treatment, which now is delivered via computer, so it's not too expensive, with the CM, with a tobacco treatment. And for tobacco, the treatments of choice are behavior therapies and medication. And in this case, we're choosing to use nicotine replacement therapy. And so what we've gone ahead and done is created some similar types of tobacco modules using the same platform. And Mike Grabinski, again, has worked on us with this. And so we now have an MET-type platform, which we borrowed from JF Eder. This is an internet treatment that's available to anybody at any time, actually, and it gives you a feedback report. It's very more sophisticated than the one we used because they're very expensive. It actually has an email coaching system where once you sign up, if you kept going, you're going to get emails every week that relate to your treatment process. Very cool. And we created some Nrt Education Modules, so if you're going to take Nrt, you have to go through these modules online to teach you how to do Nrt right. We have modules on the marijuana-tobacco connection to talk about the withdrawal syndromes, how they feed off each other, give you some impetus for maybe why you might want to quit both at the same time. We have reduction modules, so if you're trying to reduce rather than quit, we can try to help you out with that. You get the picture. So that's what we're doing now in my clinic. We have a cannabis tobacco project funded by NIDA, and we're using these procedures. We're not testing the computer at this point. We're just using it as if it's the way to go. And I think there's enough data probably to support that. So in conclusion, these are general conclusions about computer-assisted interventions for any type of SUD. They're basically highly acceptable. Lisa touched on other types of substance use disorders, cocaine, opiates. Whenever they're tried, they're acceptable, and they seem to work pretty well. They can be as effective as comparable interventions in my study and others. They can be more effective than treatment as usual if treatment as usual isn't good. And that's the case many times in our treatment agencies. They can enhance quality and reach, and they can be cost effective. What they haven't been tested with, and Lisa mentioned this, is a standalone treatment. I'm not advocating you say someone that has a cannabis use disorder and is trying to quit that you just give them our program. We don't have any data to support that they'll really do it and it'll work. It may, but it's not been tested for that, and that's not prime time yet. So I'm going to kind of finish there. This is all the folks that have been working with me on these projects through the years, both faculty members, postdocs that have worked in the past and in the present, and research assistants from the past and the present. And I thank you for your time.